Marhaba and welcome to another episode of The Doc is In. I'm Dr. Safa Hegazin. I'm an internal medicine and obesity medicine consultant and menopause specialist. And I have two of my favorite doctors in the hospital. Dr. Sadaf Brown, she's a family medicine consultant and she's also specialized in women's health and menopause. I also have Dr. Maguy Chiha. She's an internal medicine and endocrinology consultant and menopause specialist. Welcome.
Hi.
Thank you. Hello.
Yeah, thank you. So today we're going to be talking about menopause. We'll break down what it really means and why it matters for women and how a woman can navigate through that time of her life with confidence. We'll talk about real facts, expert opinions, and practical advices for those women. So if you're going through this phase of your life or you're approaching it or you know someone else who's going through it, this episode is for you. So we'll start with the definition of menopause. Menopause is when a woman hasn't had her menstrual period for 12 consecutive months. And this can happen between the age of 45 and 55 with an average of 51 to 52. It's not only about the menstrual period, but it also has a lot of symptoms that the woman can experience during that time, including physical, mental, and emotional symptoms. And this can significantly affect her health and quality of life. But the symptoms doesn't really start there, or does it, Dr. Sadaf?
It's a really good point that you make, Safa. It's a much longer journey than people realise. The average age might be 45 to 55, but many women will experience symptoms 7 to 8 years before then. And so if you go through the menopause at 45, your symptoms may start in your late 30s, when you might think you're too young to experience things like that. And then there's some extra variation as well, depending on where you come from in the world. So in the Western population, it's often 50 to 51, the average menopause, but it can occur much earlier in some Eastern countries.
Oh, that's very interesting.
Yeah.
Someone would think they're very young to have these symptoms, but not really.
Absolutely. So imagine you're in your mid-30s and you start to experience some of these symptoms. Often women get turned away by healthcare providers who don't
Absolutely.
really know that things can start this early.
Absolutely.
And also, as I'm sure we'll discuss, the symptoms can be so vague as well. So it's hard for even the woman herself to realise what's going on.
Absolutely, yes, right, you're right. Dr. Maguy, what do you think the symptoms that a woman can experience at that time? What kind of symptoms she would have?
So, as Dr. Sadaf mentioned, the symptoms can be, some symptoms are extremely vague and some symptoms are a little bit more specific. A very easily recognizable manifestation of perimenopause or the menopausal transition is when the periods become irregular. Mm-hmm. Initially, a woman might have her period a little bit more frequently, but then eventually the period would be more spaced out and a woman starts missing cycles until the period stops. But there are so many non-period or non-bleeding related symptoms. Poor sleep can start years before our final menstrual period. Brain fog, difficulty concentrating, memory issues can happen. Some women can have hot flashes. Mm-hmm. So that's a sensation of heat that starts in the chest, goes all the way through the neck and head, accompanied by sweating, palpitations. Some women become more anxious. Some women become more irritable. Many women notice that they start gaining weight, even though they haven't changed anything in a way that would result in them gaining weight. Also, the weight distribution is different. You know, we tend to accumulate weight in our midsection.
Right.
Body aches. So a lot of these symptoms are kind of non-specific, but when you put the pieces of the puzzle together, you realize that they are part of one bigger phase in the life, which is the menopausal transition. Libido can be decreased. Vaginal dryness can also start happening as well and be noted by the women. So all of these symptoms can be initially very subtle and then eventually over time will become perhaps more clear symptoms of perimenopause and menopause.
It's a good point. And also, in the first instance, women might only notice these symptoms around their menstrual period.
Absolutely.
So, you know, they might feel they just have worse PMS.
Yeah.
And even the hot symptoms can sometimes start just around the menstrual period.
Yes.
And then it's only later that it gradually happens the rest of the month. So it's difficult to spot, isn't it, for female patients and also their healthcare providers.
Absolutely.
Yeah.
Yes, I had a patient the other day. She said that she had problem with remembering words.
Yeah.
And she actually said the time for her to respond to a situation is delayed, not like when she was younger.
Yeah.
And that's she's not the only one. Obviously, we know that there's a brain fog.
Yeah.
Can you explain more?
Yeah,
about that?
sure. I mean, I think the term brain fog does it such injustice. It just makes it feel like things are not clear. But actually, we know more about the pathology behind that now, and there are actual changes happening in the brain at that time. So as your estrogen level falls, parts of your brain that control all these complex processes, so complex tasks, decision making, the structure of that part of the brain changes, and the chemistry in the brain changes as well. So, it's not just that you feel a bit foggy. You actually have genuine problems finding words, remembering things that you never had to think twice about before. You now have to really concentrate on those tasks. Imagine if you have a complex problem to solve or a big decision to make. It's that time of your life where you're making big decisions. These are all somehow suddenly very complicated. And it's desperately sad, because if you think about the age a woman would go through these symptoms, it's around about the time she might have reached her peak career. And about 1 in 5 women will give up their jobs because of this particular symptom and the pressures they find. And I'm sure you all know someone who was in a very senior role who has stepped back because of the symptoms.
Yes, absolutely. I also read that they become less resilient, less tolerant of other people in certain situations.
Absolutely, yeah.
And there's something called the tip of the tongue phenomena, where you want to say the word, but you can't find it. So a lot of women I know, they struggle with this as well. It's not only about the brain health, it's also the cardiovascular, the heart and the bone. Dr. Maguy, what can you tell us about that?
Yes, so many factors are influenced by estrogen. As we know, women in their younger years have a lower risk of cardiovascular disease than men, and that is the protective effect given to them by estrogen. And subsequently, after menopause, their risk rises. And actually, in the older population, more women have high blood pressure than men have high blood pressure. So estrogen has a very crucial role in cardiovascular health. With the lack of estrogen, so with the fluctuations and eventually the deficiency in estrogen that happens in perimenopause and menopause, women also gain central or abdominal visceral fat, and so they would have more prediabetes, insulin resistance, diabetes, changes in their cholesterol profile, so the LDL, the bad cholesterol, might go up. Triglycerides as well. All of this is driven by true metabolic changes that happen just as these hormone levels are dropping.
Right.
And for our bone health, estrogen is the main driver to build bone throughout our younger years and to maintain that bone structure and the bone strength that we've built. And as we lose estrogen, we lose significant amount of bone mass every year. So as a woman goes through perimenopause and then has completed menopause, she could have lost about 10 to 12% of her bone mass in that interval of menopausal transition and menopause. So a lot of factors are influenced by the lack of estrogen and progesterone,
and
for
these are really healthy women.
Yes,
so it's important to
absolutely.
state that, isn't it? So these are women that have lived healthy lives. They might never have had high cholesterol. Their blood pressure may have been low.
Yep, absolutely.
And actually they're suddenly met with these changes, metabolic changes.
Yes.
And it all feels rather unfair.
Overwhelming.
Overwhelming,
yes. Especially that it often is unexplained, not always correlated, not always understood or related to the perimenopausal transition. So it can also create an added state of anxiety. We know that anxiety can be part of the perimenopausal transition symptoms, but having these unexplained symptoms can increase frustration and anxiety.
Yeah. The other thing to say is that, about 80% of women will have symptoms.
Yes, absolutely.
20 to 30% really severe symptoms.
Right.
And only 50%, so only half of women will actually see somebody about this, maybe because they don't realise what it is. Like you said, it's very subtle in the beginning, isn't it?
Absolutely.
And you might not join all the different symptoms together. And so that's worrying for us, is that there's people out there who aren't actually asking for help.
Right, and those who are asking for help sometimes, and most of the time, they get dismissed as well.
Yeah.
because in general, this is a topic that we don't talk about. We don't get really enough training for. And a lot of physicians don't feel comfortable dealing with that or prescribing medication for it.
Yeah.
Right.
I mean, you know, I've seen lots of patients who've been, you know, to several different specialists with vague symptoms, for example, palpitations. So often women will go to their primary care doctor or cardiologist to have the palpitations reviewed. And it won't be recognised that might be related to their hormones, especially if they're very young, you know, sort of mid-30s.
Otherwise healthy. And
Absolutely. I mean, we're very lucky here at Cleveland Clinic Abu Dhabi because we have a special women's cardiology clinic.
Right.
Where, and you know, the team that are running that are very, very aware of how this can present.
Right.
So we have a different experience.
Absolutely.
Yeah.
We like to blame everything on stress.
Yeah.
I'll tell you about my experience with that in my clinic, because I do manage the obesity clinic, and I see a lot of women that come in during that time where they have gained weight, and you can actually gain up to 10 kilograms during that menopause transition. And a lot of them say, I haven't done anything different. They're actually, a lot of them have good lifestyle. They're just starting to gain the weight. They're doing the diet that they've tried in the past that worked for them, and now it's not working. They do complain, like Dr. Maguy said, the abdomen, they have increase in the abdomen, and they're really bothered by it. And really, a lot of this is because of the changes in the hormone and loss of estrogen. We do know that there is doubling of the fat mass in women because of that, and a lot of the fat goes to the abdomen. And this is the inflammatory, this is actually the scary and the bad.
The visceral
fat is the visceral fat, where it's related again to the high blood pressure and, you know, cholesterol and diabetes and all that, cardiovascular risk. So I do see a lot of women that struggles with that. In addition, because they've gained weight, they also have problem with sleeping. They might have sleep apnea, but also they have the hot flashes. So the sleep kind of go out of the window.
And multiple factors.
Cycle.
So what do you do? So, you know, how do you approach those women who come to you? They might not be overweight on the scales. But their body composition has changed.
Absolutely, yes. So this is where I'm lucky to have the InBody machine. We have a machine in the clinic that not only measures weight, but also the fat mass and the muscle mass. So I'll be able to tell her exactly how much fat mass she has and where our goal is, and we can adjust our plan according to that as well.
And I think it also can show us the visceral fat that we have.
And the visceral fat.
It's amazing, isn't it? Because weight and BMI just don't really give you all the information.
Not at all.
Yes. So I think everybody wants to know, if a woman present to the clinic, and what kind of evaluation would you do for her, Dr. Maguy? Like, what kind of blood work? If she asks for hormonal level, you know, stuff like that. What do you
Yes. So first of all, when we have a patient presenting for any of those symptoms of menopause, whether it is the change in her period, the weight changes, the brain fog, fatigue, you're just not feeling like herself, like her usual self anymore, we always have to do a general workup, right? I mean, we have to rule out other usual causes of diseases, thyroid, nutritional deficiencies, so vitamin deficiencies, iron deficiencies. If the period is irregular, we tend to check sometimes the prolactin level, which is another hormone that can interfere with our cycle. So definitely we should also not forget to do the usual care that we offer those patients. But we have to sit and have a careful discussion of the symptoms. And I'm glad you asked me about hormone levels, because first of all, hormone levels in perimenopause fluctuate a lot. So you can check them on different days of different weeks and have extremely different profiles, because that is part of the perimenopause and the fluctuations. But we do check hormone levels, definitely. And then we check, so we try to put those pieces of the puzzle together. Sometimes we might not reach a diagnosis from the first visit. And we have to remember that perimenopause and menopause are clinical diagnoses. They're not a laboratory diagnosis, but eventually the picture all comes together. And it might take a few visits, a few repeat tests before we are more certain that this is actually what the patient is going through. So definitely we check their female hormones, so the estrogen, the progesterone, FSH, LH, but we do definitely the general evaluation. We have a discussion about a little bit, some elements of their lifestyle too, so that we start re-cueing them about lifestyle changes that might also be responsible for their symptoms. But it's the general labs that we offer any patient who comes with symptoms, but with a really added attention to reproductive hormones, other symptoms. And I like to ask my women to keep a period diary because sometimes it's hard to remember. And so that gives us also kind of good factual data about.
And there are lots of good apps these days where you can actually track what's going on.
Absolutely.
And so, obviously the patients that we send to you, Dr. Maguy, who are very young, I noticed that you investigate them even further. Yeah.
Yes. So women who are very young, for example, who go through early menopause, it is recommended to check a bone density level in those patients as well, for sure, because as I said, we can lose up to 10 to 12% of our bone mass. And so whilst they might be quite young and not need treatment for their bone health, it's first of all good to know where we're starting at.
Yeah,
and then that would be an added factor once we start talking about hormone replacement therapy if the patient and the physician feel it's adequate. And that would be another factor that comes into the equation in the shared decision making when you balance all different profiles. We also get their cholesterol level and diabetes levels, of course, for sure, as a baseline cardiovascular assessment. Any woman has her vital signs checked. We check her blood pressure, liver function testing. So all, you want to have a bird's eye view of the woman's health. We make sure that they're up to date with their age-appropriate screening, so mammograms if they're due, pelvic exam, gynecological exam also, just to make sure that all the elements are in place and allow us to kind of take it to the next level, discussing treatment perhaps or any other intervention.
And I've also started asking about how they're feeling kind of mentally as well.
Yes,
because they might not be that forthcoming with that. But, we know that as well as affecting your kind of memory and concentration, it can really affect your mood at that time as well.
Absolutely.
So if you're someone who's already suffering with anxiety or low mood, and you've been very stable for a long time, you might find that the medication that you're using doesn't help you anymore because that drop in estrogen has really changed things. Or you might be somebody who's never had a problem with their mood. You're very happy, but suddenly you feel low, really quite low, quite depressed or anxious. You find
anxiety, panic attacks.
That's right, and lots of women stop socialising. I don't know if you've come across
they're withdrawn.
that.
They have less interest and they feel withdrawn.
Yeah, and that then has a knock-on effect on their family, their relationship. So that's something that I kind of actively ask about now, because it's not something that people often feel comfortable talking about, or even realize it's related to what they're going through.
And even women with a history of migraines who have been stable for a while have unexplained worsening or recurrence of their migraine episodes. And again, if they're young, they might not necessarily relate it to perimenopause. Neither them nor their neurologist, understandably, because there's not enough light shed on the topic. So all of these, like so many different parts of a constellation of symptoms.
Right.
And it just reflects, I think, where the patients come to us from. Here at Cleveland Clinic, we're very lucky to have colleagues who know lots about what's going on. So, I receive patients from our gastroenterologists with new onset kind of bloating, never had any digestive issues. Or foods that never bothered them. Suddenly, I've eaten this all my life. Why do I feel so bloated now? And it's actually because your hormones have changed.
That's insane that it's affecting everything.
That's right.
Everything.
This one thing that we didn't mention, because you mentioned the pelvic floor, the recurrent UTI, the urinary tract infection.
Absolutely.
Can we touch base on that? It's very important.
Yes. So as our estrogen levels drop, they also drop in the vaginal area. So the pH of the area is changed because we have less estrogen. And the bacteria, the flora, the normal flora, becomes a little bit less balanced. So they can have more yeast infections and more urinary tract infections. And so you have women of all ages, not just in the perimenopause and early menopause, but even up to their later years, having recurrent urinary tract infection. And a simple intervention that can really break that cycle of recurrent UTIs is vaginal estrogen that we can administer to those patients. That makes a huge huge difference in how often they're getting urinary tract infections.
Yes.
And if you think back to your days where you were, working in the hospital as a junior doctor, how many admissions to hospital did you see of elderly ladies with urinary tract infections?
Absolutely.
And how many of those could be prevented?
And very few were on
vaginal
vaginal estrogen.
Yeah, and this can be very serious because urinary tract infection can cause what we call urosepsis, where the patient gets really, really sick and end up being in the hospital, and then with recurrent infection. And basically with that severe infection, the mortality is increased. Yeah. So this is it's not a simple thing that we can ignore. But also it's not only the urinary tract infection, there is also dryness, which makes the sexual intercourse very uncomfortable. Irritation in that area, going to the bathroom a lot, waking up at night, going to the bathroom, which is one of the other reasons that affect their sleep. Yes. So it's just a combination of all these symptoms as well.
Absolutely.
And actually, to some people, it's just an awareness of that sensation in the bladder the whole day. It's so distracting and so uncomfortable, isn't it?
Yes.
And the beauty of it is that vaginal estrogen is safe for everybody for the rest of your life if you want to use it.
Even if they have a history of breast cancer or even thromboembolic diseases, clots, etc.
There's no one who can't have it.
Absolutely.
And there's no time limit. So, this is something that we need to share with all of our colleagues.
Right, so you can safely start it and then continue for the rest of your life.
Yeah, absolutely.
Yes, it's very important for our audience to know. Very good.
So, Dr. Safa, what can a woman do to mitigate those symptoms and prepare herself to go through that menopausal transition and phase of her life?
Yes, that's very important. So I focus a lot on lifestyle because this is where I see patients, especially for the weight, but also for the overall health. Lifestyle is very important. There actually has been some studies that lifestyle by itself can decrease the risk of cardiovascular disease, which is having a heart attack or a stroke, by 23%. So if you have good lifestyle, you can actually protect yourself and improve your health significantly. So when we talk about lifestyle, we talk about the diet. We like to encourage anti-inflammatory, meaning that has a whole food, eating the rainbows, like all the colors, less of the processed food and the sugar and the carbohydrate. We want to focus on protein. Protein is very important. You want to eat enough protein for you to maintain your muscle mass. And this is something we didn't talk about, but women tend to start losing their muscle mass after the age of 50. So protein is very important, and you want to spread the protein all through the day, so for your body to use it efficiently. And with the diet, you want to talk about the exercise. Exercise is very important. There's 4 types of exercise. This is stretching, balance, cardio, and resistant exercise. And I would focus always on resistant exercise, which is weightlifting, using the machine, maybe using your body weight. And you want to put pressure on these muscles to grow the muscles. So that's very important. 2 to 3 times a week, that would be fair. And the other part of the lifestyle, like sleep, de-stressing, making sure you're hydrated during the day, and overall lifestyle, that's very important. And with that, a lot of women can actually lose weight and improve their health with that. But coming back to the menopause, with lifestyle, we want to talk about hormone replacement therapy. It's very important for our audience to know about hormone replacement therapy. There's so many myths and misunderstanding about that. So I want Dr. Maguy to tell us about the indications and what do you know about hormone replacement therapy?
Absolutely. So hormone replacement therapy in the past used to be commonly prescribed, and then about 20 years ago or so, after the publication of a really large trial that showed that there could be increased cardiovascular risk and other health risks in patients, the use of hormone replacement therapy stopped universally, like for most women. And it isn't until in the last few years where that data was re-examined and more data came up, can we now come and say that in a carefully selected population of patients, we can very safely prescribe hormone replacement therapy for patient symptom relief. So we don't prescribe hormone replacement therapy to a woman who has any history of breast cancer. And I don't prescribe hormone replacement therapy to a patient who has a history of unexplained thromboembolic diseases, clots. So some women can develop an acute clot after, being hospitalized for orthopedic surgery, etc. We call that an explained clot. Provoked clot. So that might be a situation where, with risk discussion, we might prescribe, but any women who have conditions that predispose them to clots, I tend not to prescribe hormone replacement therapy. Now, how do you evaluate safety-wise a patient to see if the patient can fit? You definitely get that history. You make sure they have a mammogram on file and that they're up to date with their cancer screening. And then we look at their cardiovascular risk. So women with a baseline very high cardiovascular risk or who have active heart disease, recent stenting, we tend to shy away from HRT. And if a woman is very symptomatic, then with the help of our colleague in the Women's Health Clinic here at Cleveland Clinic, we can have that discussion of risk-benefit. And whenever we feel like we are treating a patient who is a little bit high risk, we tend to go through the transdermal route. I think Dr. Sadaf can talk to us a bit more about it. But what are the benefits that we expect to see? Definitely the most dramatic benefits that the patients feel are a significant improvement of their hot flashes. They might not resolve completely, but a significant improvement of their hot flashes, a significant improvement in their sleep. And this becomes kind of a positive cycle, right? As you sleep better, your energy is better, your mood is better, your concentration is better. They have more energy to exercise, right? The fat redistribution improves. HRT does not necessarily lower our blood pressure, but as a woman is overall better, exercising better, sleeping better, we know that their cardiovascular profile also improves. Definitely bone health improves.
Yes.
Definitely bone health improves. And with the use of vaginal estrogen, a lot of their vaginal dryness, symptoms, UTI improve really dramatically.
Awesome.
Yes.
That's very good. Dr. Sadaf, if a woman decided to take hormone replacement therapy, what would be her options?
Yeah, so we're very lucky now, I think. Things have changed so much. Before, we only had oral hormone replacement therapy, so oral estrogen, oral progesterone, and it has a very different risk profile to hormones through the skin. So now we use transdermal estrogen, so either in a gel that you can apply on your arm or leg, or we use a patch that's applied below the waist. And the transdermal through the skin estrogen has a much better safety profile. So Dr. Maguy talked about clots, though thromboembolic disease. So we wouldn't use oral estrogen in those women who've had any kind of thromboembolism. But we can use transdermal through the skin estrogen in those women if it's a provoked DVT without consent. We can use it in women who've had migraines, women who've had high blood pressure, all those people who were previously told you can't take oral estrogen. We can mostly use transdermal estrogen. And then progesterone, so the estrogen is the bit that makes you feel better from your symptoms, but if you've got a uterus, we have to look after that too. So so we give progesterone to protect the uterus, and that can come in the form of tablets, and it can also come in the form of a Mirena intrauterine device. And the decision is made with the patient. So some people happy to apply a daily gel, some people like to have a twice weekly patch, some women happy to have a Mirena intrauterine device and not think about their uterus for 5 years. But some women don't want anything so invasive, so they will take a daily pill for the progesterone part. So lots of options, many more options than we've ever had before. And then we usually counsel them very carefully that, as you said, Dr. Maguy, not to expect a complete cure for all the symptoms. Those chaotic changes in the hormones are still happening in the background, but the hormone therapy will just take away the extent of those symptoms. And we use, you may have heard a term, body identical.
Oh yes,
yeah.
absolutely.
So we like, So
Can
we
you explain that?
Yeah, so we, body identical means it's the same form of estrogen or progesterone that your body makes.
Yes.
In the past, the hormone therapy was synthetic, and we've really moved away from that. We do use it for some women because it's still the best option for those people, but generally speaking, we start with the body identical to give you back exactly what your body was used to. And then we counsel them about side effects. So as with any treatment, people can experience some side effects. So it's important to know what to expect. So firstly, to know the limitations. So, they might still have some hot flashes, or they might, still feel down at times, but it'll be much better. But they might notice some breast tenderness. Just like when you're having a cycle, there are times of the month where you feel you're holding more water.
Symptoms,
So you might still feel bloated. Some women have some irritation with the patch. There's tricks we can use to help with that. We can apply things to the skin before the patch, and some women just it doesn't suit them, so we can switch to gels.
I think also some women, when they start the vaginal estrogen, can initially develop a yeast infection that can really put them off from using that vaginal estrogen again. But again, just like the general symptoms or the side effects that we experience when we start the treatment that settle over time, similarly, the vaginal infections will not be recurrent. It will actually be initially because there's a significant change back in the flora of their vagina, but eventually with good treatment, they are not expected to see those recurrent vaginal infections anymore.
And then one other important thing to mention is you can experience some changes in your bleeding when you first start hormone therapy. So it's quite normal to have some spotting in those first few months, but it's not normal to have a new kind of bleed. So, you know, if you've not had periods for a long time and suddenly you start having heavy periods or bleeding with clots, or you're bleeding heavily all the time, this needs to be investigated by your doctor.
So very important to have continuous follow-up with your physician regarding, especially before deciding and even after deciding to start hormone replacement therapy.
And we tend to lose the lower dose available that is resulting in improved symptoms. But over time, we readjust also the regimen and the dose according to the patient's symptoms and how they feel.
And often younger women might need higher doses.
Absolutely.
But it's important to revisit that later on, isn't it?
Least, regularly.
And actually try cutting down at some point because their requirements might have changed.
Yeah, it's very important to mention that not one size fits all. If a regimen works for your sister or your friend, it might not work for you.
Absolutely.
So we do here at Activate Clinic Abu Dhabi individualize the approach to each woman. We do a full assessment for each woman separately, and we work together with the patient. We call it shared decision making to decide what's the best for them. If someone doesn't want hormone replacement therapy, which a lot of women either they have contraindications or they just don't want to start hormones. And I do see a lot of these women in my clinic. We do have non-hormonal therapy. So these are therapies that helps with the symptoms, has nothing to do with hormones. And some of these medications we used before, like to treat depression, anxiety, but also has been shown to improve the hot flashes and the low mood and the sleep. So we can offer these to our patients. A lot of the patients like to use herbal supplements, which can help with the hot flashes and other symptoms, like I said. I would also want to say that they haven't been studied enough in the medical field for us to give a full advice. But some women like to use them and they actually help them. So, I mean, they're it's okay to continue doing that. I would say they might help with the symptoms, but something very important, they would not have the benefits that Dr. Maguy mentioned when it comes to the heart and the bone and the brain and all that. So this is something to consider.
And actually, those women who are using those herbal medicines just need to know as well that some of those herbal medicines are not recommended for the same women that we wouldn't recommend HRT for if they have a family history or a high risk family history of breast cancer.
Absolutely.
And that's just another point to raise for us here at Cleveland Clinic Abu Dhabi. We are very lucky that we have a high risk clinic where we can actually send people who have a family history of breast cancer or ovarian cancer, and they will go and have an individualized risk based on their history. They might have some genetic tests. So if we're not sure whether they're safe for hormone therapy, they'll go and have that assessment and come back to us with a personalized risk. And then if their personalized risk shows they're at average risk, we go ahead and we can treat them. But if they're at higher risk, then we would talk to them about the alternative treatments you've mentioned. And there are new therapies coming all the time for those women.
And I like to really re-emphasize here that it's not just shared decision-making between us and the patient, but it's multidisciplinary because we have access to all of these resources here at Cleveland Clinic.
I think that's what makes us unique.
Exactly.
There are many services providing menopause care, but we have a whole team of specialists under one roof. And, you know, we meet with them all the time and we discuss these complex cases you mentioned, patients with cardiovascular disease. I've had patients I've had to discuss with our women's cardiology clinic where, you know, on paper, the patient looks like they shouldn't have hormone replacement therapy, but after discussion and careful counselling, it's actually the best way forward for that person.
Absolutely.
And we have wonderful pelvic floor physical therapists who I can't speak highly enough. So alongside that vaginal estrogen, some pelvic floor therapy is life-changing for those women.
Absolutely. Very nice discussion. That was great, having that discussion and talking to both of you. Any final remarks?
I mean, I would just say to anybody who's listening to this, or, you know, who might think, that sounds like me or my sister or my mum, just, you know, don't be afraid to come and have that conversation. You're actually never too young to be starting to experience some changes in your hormones. And if you're not sure, just come and have a conversation with either your primary care doctor or come to the menopause clinic.
Absolutely.
We're happy to see you and you know, and reassure you and you know, talk about options for you.
And it's never too early to start the lifestyle changes in advance, building our muscle before we lose it, and getting in the good habits before the perimenopausal transition happens too.
Yes. I would say it is okay to go through this phase of life. It's not a disease, but it's not okay to struggle.
Absolutely.
If you're going through this and you have these symptoms and you're struggling, seek help. There's always someone who can help you from the medical field. Find a doctor that can actually address your concern, someone who specializes in menopause, so they can offer you the advice that you need. And hopefully this discussion will open another discussions and conversations to continue talking about these subjects and spreading awareness.
Absolutely.
Yes. Thank you.
Thank you very much.
Have a
Thank
good
you.
one.
Thank you, Dr.
you.
Sadaf.
Bye.